Hey everyone, welcome back to another episode here on Doctors Go Live with me, Nina Cheryl Khan, your host. And today we are going to be talking about heart failure, the past, the present, and the future. Sounds like one of the films out of the Back to the Future series, right? But no, we're talking about the heart. So who's tuning in right now? Where are you tuning in from? How are you guys doing? Please let us know in the comment section. Of course, what would you love to know and find out in today's episode of Heart Failure, the Past, Present, and Future. Now, if you share this video out, as usual, you get to take part in our Doctors Go Live quiz, which is happening right at the end of the Q&A, where you get to win today. It is a travel pouch. So who wants to win the travel pouch? Let me know in the comment section, all right? Now, if you think you're our lucky winner, you want to stay tuned to all the Q&A with our expert for today, because you could win that travel pouch. Now, all this is happening right here on Doctors Go Live with me, Nina, and our special guest for today. So what are we talking about today? Fatigueness, shortness of breath, or swollen feet? These are just signs of aging, right? Or could it be something more serious? Heart failure apparently doesn't build up, doesn't happen overnight. It builds up quietly. So fatigue, breathlessness, swollen ankles until suddenly it is an emergency. And here's the alarming truth. Malaysians are getting it younger and younger and more severely than ever before. So in today's episode of Doctors Go Live, we're going to be joined by our expert, Dr. Kogulakrishnan Kaniappan, consultant interventional cardiologist and physician at Columbia Asia Hospital Klang. And we're going to dive deep into heart failure, a condition that affects thousands of Malaysians every year. We'll also explore why Malaysians are being diagnosed younger and younger, and the latest treatment options as well, and how you can spot the warning signs before it's too late. Welcome, Yvonne, Revati, Fatima, Kelvin. So nice of you guys to join. Ladies and gentlemen, please welcome Dr. Kogulakrishnan, or Dr. Krish for short, right, Doc?
Yes.
Okay. Thank you so much for joining us. Before we start, just want to remind you guys, at the end of the show, we've got our Doctors Go Live quiz. We've got some travel pouches up for grabs, so please do listen and answer the questions at the end, all right? Doc, so are you ready?
Yes.
Okay, we're going to do a marathon of questions. Boleh, Doc?
Sure. Looking forward.
Okay. Okay. But before that, Doc, could you share with us a little bit about yourself? Like, what do you do in Klang, and how did you get started in cardiology or heart failure? What excites you about it?
Okay, a very good afternoon to our wonderful audience on Facebook Live, and also to our charming Miss Nina. Of course, thank you for having me in your show. Right. I'm Dr. Kogulakrishnan Kaniappan. Everyone calls me Dr. Krish. I'm a consultant interventional cardiologist and a physician in Columbia Asia Klang now. I would say that my medical journey starts all the way from student days, where I'm always be interested in medicine, whereby whenever you are sick, your parents bring you to the doctors, and within few minutes the doctor knows what's going on, and with few treatments you get better the next day. So it always makes you very curious what's going on and how can they do this better than us. So when I got into tertiary education, I felt that this is where I belong to medicine. And of course, journey in medicine is lifelong. They say there's a lifelong learning. It was a very tedious process. Comes with a lot of commitments, a lot of sacrifices, but I think it will be worthwhile at the end. And what gives you the fulfillment is to know that your patients are getting better. They comes very sick, and with your treatment and the correct diagnosis and treatment, they go back home safely and with a smile, and that's what keeps you going on a daily basis. Comes to cardiology, of course, there are many other disciplines in medicine. Why cardiology? I would say because I think heart is what really matters. I'm sure you'll agree with that. And of course, it's one of the most complex, dynamic organ where a lot of things going on, and many things are still we trying to understand as we speak. And everything starts with heart, and everything ends if the heart stops. Correct. And we being a physician and cardiologist, I think we have a bigger responsibility where we were able to make a difference between life and death at some point, and to help patients. And I feel this is something of a huge responsibility and something that always give me the happiness to know that you can actually make a change in a patient's life.
Okay, got it. Now, why is it important that we talk about heart failure today, Doc? What is it that the audience watching at home needs to know?
I would say that, of course, generally when we talk about cardiology or when you talk about heart, everyone always very concerned about heart attack. I'm sure. I think my previous talk, many months ago, we were talking about heart attack, coronary artery disease, and so on. But what is life after a heart attack, right? So that's something
Mm,
that always people don't look too much into. So basically, heart failure could be uh, a standalone issue, means a patient presents as initial presentation of heart failure, or it could be a sequelae of a heart attack, right? Someone who had a major heart attack, even though despite the treatment given, intervention done, angioplasty or bypass done, there could be a residual damage to the heart function where patient remains in heart failure. So now it becomes our responsibility not only to treat the coronary artery disease, but also the consequence of the coronary artery disease, which is the heart failure. If we do
mm.
not treat the heart failure adequately and promptly, this patient can progress into morbidity and more complications such as sudden death and, of course, the risk of dying.
Okay, got it.
So
Okay, cool. So let's get straight into the slides then. Yeah. Um, so, Doc, can you share with us let's start with the basics, I guess. What exactly is heart failure? What are the symptoms and signs?
I think this time my main objective of sharing is just to share awareness what is heart failure, try to bring it down as simple as possible to for the general public, right? So the heart, you have to imagine like a pump. Is essentially a pump which pumps out blood and also receives blood. So if there is a pumping mechanism, there is a pipes where there is a vessel which acts like a pipe. So the heart receives deoxygenated blood, means blood with less oxygen, which has been used up by all the vital organs, which goes to the heart, and from the heart, it is now is being pushed forward to the lungs, and the lungs gives new oxygen to the blood, so it gets oxygenated blood. So now the oxygenated blood now returns to the left side of the heart, and
Mhm.
from there it is being pumped out all over again. So this is actually a cycle. Okay, from all over the body it goes to the heart, and from the heart goes to the lung, from lung comes back to the left side of the heart, and from there it goes all over. So wherever there's a problem in one of the circuit, or in whichever part of the circuit, actually the whole system fails. And one of the major component of this is the heart, which acts like a pump. So when the pump does not work effectively, it could be due to some various reasons. Number one, the problem with the pump itself, or the problem that occurs before the blood comes to the heart, or whether the problem occurs after the blood has been pumped out. Challenges
Mhm.
such as, number one, there's a problem in the muscle. The muscle is weak. The heart muscle is weak. For instance, in the cases of cardiomyopathy, there's actually a disease of the muscles of the heart, myocardium. In
Hi.
cases where patients having sepsis, patients having severe infection, or they have a low blood pressure for whatever reasons, right? So there is not enough blood to the all over the body, and as well as heart itself. This itself trigger for the heart to fail, because the heart cannot contract, that not much of volume, and ultimately the heart will fail. So this is only
Right.
one part of the story. So now let's put it this way, that the heart is a pump. So for the pump to work effectively, the pump has to get enough energy. The
Mm.
energy is actually the coronary perfusion. The heart receives blood to itself during the relaxation phase of the heart, which we call as diastole. right? During
Mm-hmm.
diastole, the coronary perfusion takes place. So if the heart does not receive adequate blood supply due to possible blockages in the blood vessel, the coronary blood vessel, like what happens in heart attack, the heart will fail, the pump will fail because the pump cannot work.
Mm.
Number two, if there's a problem in the number of volumes in the heart, for instance, too much volume or too less volume, or problems in the lung, any lung disease can also affect the heart because it's interconnected, as I mentioned earlier.
Mm-hmm.
So any disease in the lung in the long term will affect the heart and makes the heart to fail. So now talking about the heart itself, what is left ventricular ejection fraction? So it's basically it is a ratio, it's a mathematical calculation where there's a ratio of left ventricular stroke volume, which it actually means is the volume of blood which has been ejected out of the left side of the heart compared to the total volume during the diastole, which is the relaxation phase. So, for example, if there's 1 liter of blood during the end diastolic phase, if the heart can contract and take out 50% of that volume at one cardiac cycle during the one thing, then it is normal. More than 50%, we see is a normal heart function. So the calculation is actually that's what it means. Left ventricular ejection fraction is a fraction whereby it's a volume of blood ejected from the left ventricle compared to the total volume during the end diastolic phase. So the problem of heart failure can occur due to many reasons. Could be functional impairment,
Mm-hmm.
because either there is not enough filling in the heart, or the problem that cause improper ejection of the blood, or any structural problem, meaning there is a valve problems, or there could be problems in the coronary perfusion, or the problems in terms of muscle itself, cardiomyopathy. So if we talk about the causes of heart failure, there are many causes. We talk about ischemic causes, which are due to coronary artery disease. We can talk about a non-ischemic causes like the problems in the structure, problems in the muscle, and so on and so forth. But essentially, once you find the cause, now we have to narrow down to how do we classify heart failure. For us
Mm-hmm.
to do that, first the patient needs to know what is the symptom. Symptoms mean what do they feel as a patient? What are the things that they complaints that they have? Commonly, patient will complain of short of breath. They might feel short of breath while they're doing extra work, while they are lying down on bed. They realize that at night they cannot sleep flat. They have to sleep with two pillows up. So that is one of the early signs of that patient might have heart failure. Other than that, some patient will notice leg swellings. They notice that out of suddenly both the leg is swollen. And most of the time, it might be usually it's painless leg swelling. Usually, if you have an infection in the leg or some blood clot in the leg, you might have pain. But if you have a painless leg swelling and you notice the swelling is increasing from the foot all the way up in an ascending manner, then one of the reason could be heart failure. Some patients will feel very breathless because the water is accumulated in the lungs. Some patients will realize that now the pants or their clothes does not fit anymore. They feel that they're putting on weight very drastically. One of the reason is because the abdominal distension. Now the water accumulates in the third space in your abdomen. These are the few things that happens when a patient develop heart failure. As you rightly put in your first statement that you say this is heart failure is not something that happens just a day. It is a gradual process. And usually during the early phase, it is very insidious. Patient might not notice it. The moment they have symptoms, I'm sure some damage is already done. But the earlier they come to the doctor to detect the problem, the better it is. So now, once they come to the doctor, what does the doctor do? First, they will take a good history to know whether this patient have all the complaints that I mentioned earlier, whether they have shortness of breath, whether they have difficulty sleeping flat, do they have leg swellings, do they feel very breathless climbing up the staircase, or do you feel that always tired? These are a few things like including lethargy. Once we do that, we do a full physical examination. We look for any signs um, that can inform you that this patient may have heart failure. One of the things that we look for leg swelling, and most importantly, pitting pedal edema, we call it. Number two, we will check whether there is any signs of accumulation in water in the lungs. And of course, we also look for signs where there's any signs of accumulation of water in the abdomen, which we call ascites. And sometimes we also look at the neck vessel to look for any signs to say there is a raised jugular venous pressure, which actually indicates what's happening internally inside the heart. That we know that the pressures inside the heart is very, very high. So once we have this physical examination, the next most important thing to do is a echo assessment, which is the ultrasound of the heart. So it is a non-invasive test, just like when a lady is pregnant, the gynae doctor will do an assessment to look at the baby size and parameters and all that. Similarly, we do the same ultrasound assessment of the heart. We will look at the structure of the heart, we look at the functions in the heart, we will look into the flows in the heart and the pressures in the heart. From there, we come with a conclusion what is the ejection fraction of the heart. So essentially, the most important number is 40% and 50%. Anything below 50%, we say this is heart failure. And from the 50% and below, we will then categorize how bad is the heart failure. Anything below 40% is, of course, heart failure with reduced ejection fraction. That is the name given by the European Society of Cardiology and the American Society of Cardiology. Is one of the things that has been in the guidelines. So anything less than 40%, we call it heart failure with reduced ejection fraction, where it's very significant heart failure. Anything between 40 to 50, we call it mildly reduced ejection fraction. And anything above 50, now this is where the dilemma is. A lot of times, when we do an echo assessment, some patient might have ejection fraction of 56%. So this is why nowadays and for the past few years, we realize that heart failure with ejection fraction more than 50% is often overlooked. They are often misdiagnosed because they are more than 50%. They've been labeled as normal or they've been labeled as asthma and everything. Sometimes we have patients coming to you with shortness of breath and they be investigated and we realize that the ejection fraction is actually more than 50%. So whenever there's an ejection fraction of 50% and above, we must be more prudent in our investigation. We must look hard whether they have any signs to say this is heart failure. If yes, we have to do further detailed assessment to prove that this is also another component of heart failure, which is heart failure with preserved ejection fraction. So now there's three categories of heart failure. One is reduced, which is less than 40,
Mm-hmm.
might reduce 40 to 50, and another component which is preserved ejection fraction, more than 50%. If a patient who comes with shortness of breath and we have done our detailed assessment and we realize that and we can prove that it is none of the above, then we have to start looking for other causes. It could be asthma, it could be COPD, it could be GERD, which is your reflux disease, many other things that can also cause shortness of breath. Before we think of other differential diagnosis, we must look hard whether we are dealing with a patient with heart failure or not, because early
Right.
treatment is essential.
Okay. That makes a lot of sense. Right. So we can go to the next slide, yeah, Doc?
Yeah.
All right. So what is this slide about, Doc? It looks really scary, but I'd rather you explain it before I jump to conclusions.
So basically, in heart failure paradigm, we always talk about survival curve in heart failure. We must imagine that heart failure is a chronic disease that progresses over time, with or without treatment, right? And our aim in heart failure is number one, to prevent hospitalization. Number two, to reduce the symptoms. Number three, try to reduce the risk of mortality, which is death. And how do we do it? Number one, by educating them regarding their disease and also the family members. And we will advise them about compliance to restriction of fluid. Number three, we have to ensure them they are compliant to the medication that has been administered. And four, we try our best to make sure patient is stable and do not go into decongestion or that requires hospitalization. Because in heart failure, based on many research, we have shown that each hospitalization for a heart failure patient is a sentinel event. There is a high chance that patient can die during that admission. And if we also realize based on our clinical experience, every heart failure admissions becomes longer and longer. For instance, the first time patient admitted, probably patient stays for a few days, they will get better. After a few months, they get admitted again for heart failure, the admission becomes even 1 week. The third admission may require ICU care. The fourth admission could be deadly. So that is why it's very important to ensure we initiate treatment as early as possible to try to prevent this survival patient going into this vicious cycle.
Okay, got it, Doc. In the meanwhile, if you guys have any questions whatsoever, please feel free to list them down in the comments, and we're going to answer it after the Q&A kind of thing. Yeah. Doc, what about for Asians? So apparently we're getting heart failure younger and more severely. What is happening? Is it lifestyle, genetics, or is it something else? Please do share with us.
I think this data is also quite surprising
Outdated.
for us. It's
Oh,
based
oh,
on
okay. Uh-huh.
all the Asian data that we have on heart failure. We realize that more heart failure patients are getting younger in Asia, and not only they are younger patients, they have severe symptoms. And one of the main reason for this is if you realize we have more diabetics patient in Asian population, we have more hypertensive patient and dyslipidemia patient. These are the three common reasons for heart failure or cardiac problems. And
Mm-hmm.
we should not be proud that we are one of the leading nations with diabetes and obesity as well. So these are the one of the few risk factors for heart failure. So it's not so surprising that nowadays we are seeing more patients with heart failure. Number two, is also probably related to genetics and all that, but I think we need more research into that landscape. But as of now, what we know is that the average age of Asian heart failure patients are around 60 compared to the European population. And of course, when we talk about the severity of disease, most of our Asian patients comes late to hospital. It comes when the symptoms is severe enough. And one of the main reason probably lack of awareness, or number two is that denial. Number three probably is that they might also try to seek other alternative treatment before they come to see us.
Okay. So the Asians like to come late lah, basically.
I wouldn't say come late. This is purely based on the data
Data.
that's given, but I must say that nowadays Malaysians per se are very much keen into health screening and all these things, and this is where it's a very good way of us detecting the disease early.
Okay. So
Why I
health
think the
screening
government
is good.
also trying to educate uh, our population and our people to actively involved in health screening.
Okay. Got it. And is this where we talk about NIHAR? Is it NYHA or in later?
Actually, it's NYHA is a functional classification of heart failure,
Mm-hmm.
where we classify heart failure into four. NYHA 1 to 4, where 4 is the worst severity, 1 is the least.
Oh, okay. Okay. Right. Okay. So let's talk about how serious the problem of heart failure in Malaysia is. Could you share with us that?
I think globally, the heart failure prevalence is around 2%. There's more than 64 billion people worldwide suffering from heart failure. As I say, it's a chronic disease. And now, knowing that the latest statistic, Malaysia is moving toward an aging nation, right? We have more and more people uh, above the age of 60, right? And some more, the prevalence of heart failure is increasing in Malaysia. We foresee the healthcare burden to increase, probably double or triple in the next few 5 to 10 years. And one of the very reason is because, number one, despite treatment, optimal treatment, the disease will progress, but at a slower rate. And it is preventable as long as we can treat the underlying cause, number one. Two, for patients to optimally take all the medication and come for regular follow-up. If one of these fails, it's very difficult to mitigate the risk by heart failure.
Is that for you, Doc? Okay, right. So that is the burden of heart failure in Malaysia. All right, could you share with us what this Malaysia National Heart Failure Registry is, or MyHF, right, Doc?
Uh, this is the registry done by our National Heart Association Malaysia, by
Mm-hmm.
where all the esteemed cardiologists, senior cardiologists, and all the team uh, in the National Heart Association of Malaysia. So what they do is they do observational data, mostly prospective, multi-center registry of all the chronic heart failure patients in Malaysia over the past many years. So this data was usually is published every our National Heart Association National Congress during, and also in the morbidity and mortality meetings, and also in the national statistic meetings. So one of the things that we found out during the registry is that across Malaysia, including government, private, and also um, clinics, we noted that the prevalence of heart failure is increasing over the years. And if you look at the population, the full spectrum of heart failure group, it is almost equivalent. As I mentioned before, there is a group of patients with reduced heart failure. There's a group of people with pre- preserved ejection fraction, which is more than 50%, and one group is less than 50%. Another group is in between. If you look at the statistic, there's 40% of them is belongs to less than 40% ejection fraction. 41 to 49% is what, when we talk about heart failure with mildly reduced ejection fraction, anything more than 50% is preserved. So what they did is, over the past 3 years, they go through all the statistics, all the patients in all these various hospitals. They managed to sample around 2,673 patients. And can we go to the next slide?
Definitely.
And they realize the most predominant component of patients are in the reduced ejection fraction. So almost 67% of these patients out of the 2,600 patients that will be sampled belongs to the severe heart failure group, which is less than 40%. But there's also strikingly important that you realize the number of preserved ejection fractions is increasing. It's almost half. So this is also equally important group that we have to focus on.
Hmm. Okay,
Next slide.
next slide.
And now looking at this data looks at the heart failure treatment pattern prior to admission and at discharge. So what is data trying to inform us that out of 10 patients, 9 patients at least receive one heart failure medication at discharge, compared to prior to admission. And that is why in hospitalization treatment is essential. And this is where the biggest opportunity for us to initiate the heart failure therapy.
Next slide.
It's like, and how do we diagnose them? What are the tools that can help us to diagnose and monitor their progress? Is a marker which is called anti-pro-BNP or BNP. This is one of the markers that's very essential for us to diagnose a patient with heart failure and monitor their progress after treatment has been initiated.
Got it.
So now, what is the takeaway from the registry is that first, everyone realized there is a very high disease burden in Malaysia, and whereas almost 67% of patients who are belongs to the very severe heart failure group, which is less than 40% ejection fraction. And you can note that 2 in every 3 hospitalized heart failure patient belongs to this group. And most importantly, there's a very high readmission rate, meaning to say a patient admitted, they get better, within the next 3 months, they get admitted again, despite all the available therapies available is being given to patient. And
Why is
also,
it? Why do they get readmitted? But you continue first, Doc.
okay, we'll go into that later,
Huh.
right? Um, and another takeaway is that Malaysians suffer from heart failure at a younger age, with a mean age of 60, compared to the European counterparts. And de novo heart failure, meaning for newly diagnosed heart failure, is one of the important hospitalization diagnosis. Means there's almost 34% of patients coming to hospital with the first diagnosis of heart failure. And most of these patients have other comorbids, be it they have diabetes, they might have hypertension, they might have high cholesterol, or they might have kidney disease. And this is what's very important. The average length of hospitalization, meaning if a patient admitted for heart failure, the amount of time they are taken to be discharged for an average heart failure patient is around 7 days. So they stay almost 1 week in hospital before they get better. And this admission length becomes longer and longer if they keep readmitting. And this is what the survival curve informs us.
Wow. Okay. Sounds really serious, Doc. Kind of thing. Okay. So now that we see how serious it is, we know what some of the symptoms are. Could you share a little bit about the treatment? Maybe go into the brief history of it.
I mean, this is for the interesting part of it. So, since we talk about cardiac and heart failure, and as I mentioned earlier, heart failure is in essence is a pump with a lot of connection, circulation. So, William Harvey in 1628 is the first person who describes circulation of the heart. And of course, when we want to listen to any heart murmurs or any symptoms, we use a stethoscope, right? The stethoscope is invented in 1890 by Laennec. He's the first person who do it. And when we talk about heart failure per se, in 1958, one of the very first medication used is your thiazide. This is where it was discovered. And since then, the heart failure medication, the pharmacotherapy have grown leaps and bounds over the years, and there's been new therapies available. But yet, we realize the disease burden is increasing. We realize the amount of patients dying from heart failure is equally increasing, and this is there are many reasons to it. There are many factors that leads to this, and that is why I think awareness is one of the key things that we have to inculcate in our patients.
Okay.
So looking back many years ago, the thought process when we treat heart failure is there's a lot of water inside the heart, and in your body we have to take out the water. So you have to. It's more of the fluid management. So that is where the initial model, including cardiorenal, is to give digoxin and furosemide to the patient. Furosemide is a water pill. In simple words, it tries to flush out the excess water in your body, but at the expense of kidney injury. And so on, the thinking and the knowledge progresses. As we have more evidence, we realize there's also a component of afterload and preload. This is where I mentioned earlier the problem starts before the blood enters the heart or after the blood exits the heart. So to trigger or to tackle these problems, their newer medication were invented and administered. And later, they also realized heart failure not only about fluid management, not only about managing afterload and preload, it's also you need to manage many neurohormonal imbalance. That's where key medications like your ACE inhibitors, your beta blockers, your mineralocorticoids, and all that has been comes into play. And now for the past 5 years or so, it's not only tackling fluid, not only tackling hemodynamics and neurohormonal, we also now talk about reverse cardiac modeling. Reverse cardiac remodeling meaning to say that as the heart goes through heart failure, essentially it grows bigger and bigger. That is why one of the key things that they do is when you do an X-ray and you see the heart is big, everyone suspect, okay, this patient may have heart failure. But that has to be confirmed with the ultrasound of the heart echo assessment. But now, can we make it smaller again? Can we make it better again? So this is when the heart fails, it goes through cardiac remodeling. So can we reverse it? So this is what we are trying to achieve or trying to work towards with. And there are some medication that has proven to help with these efforts.
Okay, awesome.
Has been put into guidelines, and this is where we talk about when we talk about the severe heart failure, the one with a ejection fraction less than 40%. There are four pillars of heart failure. The first pillar is your beta blocker. The second pillar is your ARNI, which is your angiotensin renin uh, receptor blocker. The third is your MRA, and the fourth, the newer one that has been comes into play, is your SGLT2. So there are four medication essentially must be initiated with someone with a heart failure with reduced ejection fraction.
Okay, so four different types, huh? And
Yeah.
this one, this would be the new one?
This
Or
basically
oh, not
is
yet. Mm.
looking into the various things that we do when we manage heart failure. As I mentioned earlier, it's not only about symptom controls. We try to manage as a whole in a holistic approach where we have to treat the underlying problem and also try to prevent the complications. Firstly, patients with heart failure will go into volume overload. So we have to give them some medication to remove the volume, remove the congestion so that they feel better. If the cause of the heart failure is a problem in the coronary vessel where it could be a blockages, then you treat the blockages with a stenting, angioplasty, or with a bypass if it's required. Hopefully, it helps to improve the heart failure. If the problem is not ischemic, means it's not due to coronary ischemia, then you treat the patient to stabilize the cardiomyopathy. At the same time, there are many other components that can also affect the heart to become weak. For instance, if a patient have an irregular rhythm, such as atrial fibrillation, over a period of time, it will also lead to heart failure. So now the key is to treat the heart failure. At the same time, we treat the atrial fibrillation.
Mhm.
And this is where the chart, this whole table shows you. And if let's say the heartbeat is too fast, and we try to aim for a slower heartbeat. If the problem lies in the valve, if the valve fails, either the valve is too tight or too flail, like for example, a mitral regurgitation, which is the mitral valve is very leaky, that can also lead to heart failure. So now we treat the heart failure and also try to treat the valve. We can treat the valve surgically or non-surgically using transcatheter methods. It's the same story with aortic stenosis. We have
Okay.
something called TAVI is available and also surgery is available. So we have to treat the underlying cause. Otherwise, just treating the heart failure may not be enough to effectively reduce the symptoms.
Okay.
So these are essentially to inform you that despite all the treatment available, there will be a small population of patients still progress into advanced heart failure, where the heart, despite all the medication given treating all the underlying cause, patient still goes to the advanced heart failure, which we mentioned is the functional class, the NYHA class of 4. At this point, there are only few available options. Patient has to consider heart transplantation. Number two, while waiting for heart transplantation, they might consider mechanical cardiac support devices, or it will be purely medical therapy. This will be based on patient and clinicians' joint discussion.
Okay.
And of course, to treat the heart failure is not always about medication. It's also we have to consider non-pharmacological, which means exercise rehabilitation, and also to improve their symptoms and quality of life. The exercise rehabilitation really helps. We also go into multi-professional disease management, meaning by not only treating heart failure, you also treat the diabetes. You must also treat the hypertension. You must also treat the cholesterol. Otherwise, things will not get better.
Okay, got it.
So this table actually illustrate what are the medication available for another subgroup of heart failure, which is mildly reduced ejection fraction, which I think we have discussed earlier.
Okay, got it. To show it. And this one, Doc?
Now, this is the another component of heart failure, which I mentioned to you. Almost half of our heart failure population belongs to this group, which is heart failure with preserved ejection fraction. There are very good medication available now, and the medication has proven to have mortality benefit, means that it helps to reduce the risk of dying from heart failure by initiating this medication. One of which is the SGLT2, your dapagliflozin and empagliflozin. And
Got it.
of course, we also talk about the diuretics.
Okay, cool. So those are what's available right now, right, Doc? What about new therapies? What's the latest, if you can share with us?
As we speak, there are more newer therapies available, but I'm not be able to share it because we don't have the final outcome of the trials yet. However, these are the few things that has already been published and also been initiated for patients with heart failure. Number one, in terms of diuretics, when the initial diuretic therapy such as your furosemide and bumetanide does not work, we have a new therapy called tolvaptan. This is another drug can work synergistically with the other diuretics to help reduce the congestion. And the second one is finerenone. It's a non-steroidal MRA. It's one of the four pillars of heart failure therapy. Is your MRA. So now we have a newer agent which actually works better for patients with diabetes and kidney disease who also have heart failure. And the third one is very simple. This is also being used in heart failure for patients who have recurrent hospital admissions despite already on all the four important medication.
Okay, got it. And what's this slide about, Doc?
This, I would say, is a very interesting slide. This is one of the interesting paper. They talk about overall view of heart failure. So we are talking about epidemiology. As you can see here, the prevalence is around 1 to 2% of adults. The incidence of heart failure in Europe itself is 3 out of 10,000 patient years. So now, looking into pathophysiologies, there are a lot of scientists are now looking into newer therapies since we know that despite having all the optimal therapies available, the disease burden is increasing, more patients are dying of heart failure. So, uh, a lot of research and effort is put into place where we can try to mitigate the risk at a micro level, where we talk about myocardial injuries, we talk about inflammation to the myocardial cells, and also the autonomic nervous system dysregulation. So there are many trials ongoing to look into this, see whether if we tackle at that point, will that help in heart failure in the long term. Besides that, there are also trials and research which shows a patient with obesity and heart failure, they do not do well. So there are trials like STEP-HF which have shown that some diabetic medication given to a patient with diabetes, obesity, and heart failure actually makes a lot of clinical improvements. So there are medication that is available that can be used for this group of patients, such as your GLP-1. And of course, there are many positive trials which also showed that a patient with heart failure together with iron deficiency, if we correct the iron deficiency, patient symptoms improve. So these are the
Okay.
things, aspects that we look into, not only treating the heart failure, we also look at other comorbidities, other diseases that can be corrected in order to help reduce the risk of progression of heart failure.
Okay, because
Now,
they're.
talking about diagnosis and prognosis, right?
Mm-hmm,
This is where I think the future holds. With the advance of AI, we
mm-hmm.
hope many new technologies and algorithm will be available for us to make early diagnosis for patients, and also detection can be much sharper, more accurate with AI assisted imaging. And probably in terms for patient itself, we have a wearable where patient can detect their weight, their pressure monitors to assess whether they're already having so much water inside their pulmonary artery. These are the things technology is readily available now, and hopefully
Wow. Okay.
more research will go into this.
That sounds exciting to me, Doc. Kind of thing with new tech and stuff like that. And in fact, since we're talking about it, what is congestion remote monitoring? It sounds very high tech and exciting.
Okay, I think this is the extent of what we have discussed earlier. These are these are the more advanced monitoring uh, for patients and also for clinicians. Usually, when we have a patient with heart failure, we always advise patient, please look into your symptoms. See whether when you're at home on medication, do you feel more breathless? Do you notice that your leg swelling increasing? Please monitor your weight daily. If your weight increasing in such a short time, it might mean that you're putting on so much of water retention, and also monitor the urine output. So this is more of a very objective assessment. But now we have devices that we can actually put into place for patients, so that with these devices, not only the patient but the clinician also can know that, okay, my patient now probably taking too much water. We need to give them a call and say, okay, you have to reduce the water and come to see me in hospital as soon as possible. And these are the monitors that we actually put in place in the pulmonary arteries, right? Where it is quite safe. And there's many studies have shown that these trials have shown that these monitors makes a lot of improvement, clinical improvement. In fact, for example, if you look at the pulmonary artery pressure monitor, PAP sensor, there's few trials like Guide HF trial, MEMS HF trial, Monitor HF trial have shown that almost 40% reduction in heart failure hospitalization just by monitoring. Because if you can monitor very well, you can actually titrate the amount of water that you take daily, and we can also titrate our medication for patient based on the calculation or the data given by these monitors. So in that sense, we can prevent hospital admission even before it happens.
All sounds it. But the device, is it outside or do you actually put it in the patient? How does it work?
It's actually inside. It's more invasive.
Okay,
But it's
got it.
not for all patients. These are the This is a very special group of patients who comes in with recurrent hospital admission despite all the medication given, and these are the patients who are very fragile. So this group of patients where we want to monitor them closely, this is when
Hmm.
we consider this. But this is not very commonly done for everyone.
Okay, got it. Kind of thing. Sounds great. So I think that's our last slide, yeah, Doc. Yeah. Okay, Doc. So if we were to summarize today's discussion, what before we do that, what in your experience, what's the biggest or most common mistakes that people make when it comes to heart failure? In your experience.
I think one of the common mistake is that uh, they come late to see a doctor.
Okay.
They already have the symptoms for many months, but they
Okay.
might reject the symptoms, saying that it could be just I'm tired, probably I'm overworked, lack of sleep. Uh,
Okay.
I think it's very common for all of us to how do I put it, to
To dismiss it as oh just
dismiss
tired,
dismiss
make
as
excuses.
something not very serious until
Mm,
things really get more challenging for them. But
got
my
it.
advice would be, even if you think it's a very trivial thing, it's better to have it checked. The earlier you
Mm,
check, and
the
if it
better.
turns out to be normal, is well and good. And if it's not normal, at least early detection saves lives, and
Mm.
we can do a lot of improvement at the early stage.
Right. So would that be, I mean, if we were to summarize then today's discussion, what would be some of the most important points that you want the audience to take home today?
I think health screening plays a big role, and managing heart failure is a long-term commitment. I will always tell my heart failure patient, the moment you have heart failure, is not about finishing a race. Heart failure is a marathon, a lifelong marathon. So discipline, commitment, and trust between the patient and the doctor is very important. Then only we can do the best for our patients. And patients themselves know that they play a big role. Compliance and their lifestyle makes a big change in improving their outcomes in heart failure.
Okay. And last question, what's the one thing every Malaysian can do right now to protect their heart, in your opinion?
There's many things you can do, but the first
No,
thing you do is
if
that
there's only one.
uh, get yourself checked if you think you are unwell, or
Okay.
even if you think you are well. It's always good to have it checked once in a while, especially if you have any risk factors or family history.
I think that's a brilliant advice. Okay, cool. So I think that's the end of our doc sharing. We're going to go into the Q&A now, and we've got a couple of questions before we go into the quiz. So I've got a question from Yiki that continues from the last one. So screening, yeah, doc. If there's one thing that you do, how often should should a person do heart screening? Is it like once in 6 months, a year?
I believe if your screening is normal, annual cardiac assessment is sufficient. You can do once a year, unless there are some abnormal readings or abnormal signs, then we have to do it more frequently.
Okay. And this question is from Elvin. Prevent is better. Actually, I have a question which kind of goes with that. So we spoke a lot about symptoms, treatment, and some of that. Can it be prevented, failure? If so, how?
First, for us to prevent heart failure, we have to make the earliest diagnosis. And of course, we have to look into what causes the heart failure. If it's poorly controlled diabetes is what leads to heart failure, then we have to treat the heart diabetes very well. So if we want to prevent heart failure, you have to make sure all the risk factors are all well under control. Risk factors such as coronary artery disease, smoking, diabetes, hypertension, cholesterol, irregular rhythms, many other things. So for us to prevent heart failure, the first thing we do is if you're unwell and you have been initiated treatment for whatever disease you have to keep it under control. That would be one of the main thing that the key takeaway from this.
Okay, like what you shared just now is the life after the heart failure kind of thing. The other question is, hang on, okay, from Nor Asila. If we have a heart attack symptom, then we change our lifestyle. Can we prevent heart attack? Because it's kind of related to that question, right?
If you have symptoms of heart attack, I would advise to get checked with a cardiologist and get it treated first. So once the treatment has been rendered, either is with medication or if the patient require angioplasty, which is stenting or bypass, after that the treatment continues. The treatment continues, meaning to say that the patient has to continue taking some certain medications and as well taking care of their lifestyle, making sure they exercise regularly, making sure they're eating a balanced diet, and following all the other lifestyle changes that has been advised. With that, we hope we can reduce another heart attack.
Okay, hope that answers your question. Yiki has a question. How long is the swelling in the leg last? One of the symptoms of swelling in the leg, right?
The swelling in the leg can last as long as it is not being treated. We have patients who have swelling up to 3 weeks, then only they come to see us. So it do not just go away without a proper treatment rendered. So that is why if you notice you have swelling and the swelling remains at least for a few days, please get it checked.
Okay, got it. So another question from Miki is, and I'm going to put two questions side by side. Is heart failure a lifelong condition? Can heart failure be reversed or cured? Similar but somewhat different way of
Heart
asking.
failure is a chronic disease. In other words, we can say it's a lifelong condition. Can it be stabilized? Yes.
Reverse.
With proper treatment, proper management? You can make heart failure stable. And we
Mm-hmm.
have good medications now that has proven that it can help to reverse it to a certain level. We have patients with all the four pillars of therapy, when they are compliant, all the other risk factor has been under control, where they initially came in with a very weak heart, let's say ejection fraction less than 40%. Over the 6 years or 1 month, 1 year, when we review them back, the heart function has improved tremendously. But
Wow. Okay.
even when they improve, we must continue treatment because they can go into relapse anytime.
Okay. So which goes into the next question. Are they on medication forever, and what happens if they skip the meds?
So I think to answer this, yes, they have to be on medication on lifelong basis, but probably as the symptom reduces, the number of medication can be adjusted to a certain amount, probably at the lowest dose or the highest dose, depends on what is the cause of the heart failure. Uh, the second question, not only for heart failure, for any disease per se, we should not skip medications because then the outcome might not be good.
Okay, sounds good. All right, I think it's time that we go into the quiz. All right, so it's quiz time. So, as mentioned earlier, as part of the show, we have some travel pouches up for grabs. But what do you need to do in order to win? First, you got to share this video out to public, share at least 3 times. Remember to set the share post to public so that everyone can see. Next, answer the 3 questions that we're going to be showing on the screen in a single comment, and you're on your way to win the prizes. So share this video out 3 times, set the share post to public so everyone can see, and answer the 3 questions that we're going to show on the screen in a single comment, and we will select 3 winners based on the correct answers and shared posts. So are you ready? Let's take a look at the question. First question is, heart failure is usually a disease of old age. True or false? Heart failure is usually a disease of old age. True or false? Second question is, heart failure can only be detected at a later stage. True or false? Heart failure can only be detected at a late stage. True or false? Early detection and treatment can stabilize and potentially improve heart failure. True or false? Early detection and treatment can stabilize and potentially improve heart failure. True or false? Let us know your answers in a single line in the comment section. Let's go back to the Q&A, and then we'll announce the correct winners. Yeah. Amira's question is, Doc, have you seen or know of anyone who completely recovered from heart failure? What did they do? I think it's kind of a repeat, but let's hear it from you.
I think probably we have to rephrase the statement saying that uh, not completely recovered from heart failure. Since heart failure is a chronic disease, you can be symptom free. Means you
Okay.
have no symptoms, you can lead almost near normal life, do whatever you want with a bit of restriction in terms of fluid. You have to take medication regularly. With all that, having said that, you may prevent admissions by staying stable in terms of heart failure. Just make sure that you come for regular checkups and all that. So we do have patients for many years just on medication. They are stable. They can do their daily function. They work like normal, but with a little bit of limitations. So this could be the group of patients that we say that almost stable on heart failure, chronically stable on heart failure. But whether
Okay.
the heart failure can completely be reversed, it all depends on what is the underlying cause of heart failure, what triggered or what caused the heart failure. So we have to look into all that.
Okay, got it. Next question is, how often will I need to see a doctor for heart failure treatment?
Of course, at the initial stage, to ensure we get the correct diagnosis, we want to know why the heart failure uh, happens in the first place. We have to do a lot of investigation. We have to assess the patient very closely. That's one. Once we have the diagnosis and the underlying cause, we have to start treating the cause. So this will require hospital admission and, of course, close clinic checkups. And usually, the first initial few months, we will regularly see patient in the clinic as we adjust the medication to ensure the best possible results. Once patient stable and they have no symptoms, then the follow-up probably every 3 to 4 months once.
Mm. So in the early stages, every month or every week?
Depending on our, we have patients who we see within 2 weeks. Then once they're stable, we only see them every 4 5 months. Depends on. I think there is no right or wrong in this. For each heart failure patient is different. So in that sense, I would say each patient's treatment is tailored to that patient's problem. So some
Okay.
patients we see them very frequently. Some patients we only see them every 4 or 6, 5 months once, depending on how stable they are on medications.
Okay, got it. Right. One last question from Joy and Jazz. For health screening, should we include stress tests, lung x-ray in the package?
I would say it's very advisable to include stress tests and lung X-ray. These are very common things and very important things that we need to know.
Okay, got it. So make sure you include that, yeah, in your test. All right, we've got our winners. How many of you guys want to know who won? Let us know in the comment. But before we announce the winners, let's take a look at the questions again and what the correct answer is, yeah? So quiz question. Heart failure is usually a disease of old age. Is it true or false, Doc?
False.
Right? It's actually, we're getting younger and younger, right? You don't need to be old to have it. So heart failure can only be detected at a late stage, true or false?
False.
There are early symptoms, which is what this whole episode is about, right, Doc?
Yes.
Kind of thing. So early detection and treatment can stabilize and potentially improve heart failure, true or false, Doc?
True.
Exactly. So basically, do health screening, correct? Kind
That's
of
the
thing.
aim of this awareness, right? That we are trying.
Yes, exactly. Kind of thing. Okay. Hang on, yeah. Okay, so the winners are, let's take a look. The winners are Yvonne Chang Ai Hua, Abe Zulnaide, and Elvin Lam. Congratulations to all our winners. That's Yvonne Chang Ai Hua, Abe Zulnaide, and Elvin Lam. All right, so stay tuned. You'll be getting a message from us in your Facebook, so be sure to check it out to find out how you're going to get your price of the travel pouches. All right. The rest of you, don't worry. There's always going to be another episode and another quiz. So definitely tune in to the next one. All right. Thank you so much, Doc, for all the time that you spend with us today. I clearly have an understanding, and it's important to do health screening every year if there's anything that I got out of it. And also, if you have heart failure, it's a lifelong process. Don't think it's about the surgery and whatnot. It's a dance, right, between the doc and the patient, kind of thing. The more you dance and have a great relationship with doc, the better it is, kind of thing. Right, Doc?
Yep. Thank you
Okay,
very
cool.
much. Thanks again for this wonderful opportunity to share about heart failure. I hope our audience will be able to take away some key points and share with their family and friends. And
Yes, definitely. The sharing part. So if you know of anyone where this information, the tips, and the insights will be really useful, please tag them in the video and share them out because it's going to make a difference to everyone out there. Any last words, Doc?
thank you very much, and wish you all the best.
All right. Thank you. Goodbye from us on Doctors Go Live. We'll see you in the next episode.
Thank you.
Bye.